AI in neurology. Now I discuss about one of the most commonly encountered movement disorder in our daily OPDs, that is tremors. It is defined as an involuntary rhythmic and oscillations of a body part caused by the alternating contractions of the agonist and antagonistic muscle groups. So clinically, tremor is broadly classified into rest and action tremor. Rest tremor is tremor occurring in a body part when it is completely supported against the gravity and it is not voluntarily contracting. And action tremor is when the body is actively contracting. When the tremor occurs in a body part, that is action tremor. It is further divided into kinetic, isometric and postural tremor. Kinetic is simple kinetic, intention and task specific. Intention is the frequency of the tremor increases while approaching a target, and task specific like during writing and while playing music and while playing golf, like that. And postural tremor is either position independent and position dependent. Position dependent like wing beating tremor, when we keep the arms in front of the chest in abducted position and arms flexed at the elbow. Next, recent classification is updated in 2018. It is based on the axis 1 and axis 2. Axis 1 is based on the clinical features and axis 2 is based on etiology. Based on clinical features, it is either historical features like age of onset, chronology and progression, and tremor characteristics like whether it is occurring at rest, action, activation and relieving procedures, and associated signs like bradykinesia, dystonia and other cognitive impairment and additional laboratory tests. And based on axis 2, that is etiology, whether it is genetically acquired, genetically defined, idiopathic or acquired. So every one of us must have encountered tremor in our life at least one time. That is due to increased sympathetic activity, that is enhanced physiological tremor. It is usually not visible because of its low amplitude, but it has high frequency in the range of 7 to 12 Hz. It is typically a fine postural or kinetic tremor in the hands and fingers. Next, we go to a case of a 42 years old female who presented with tremor while writing and doing fine tasks since her college time. She noticed a progressive change in the handwriting. Mother has a similar complaint. On examination, there is no tremor at the rest while the hands are supported against the gravity. And on asking the patient to outstretch his hands, there is a bilateral fine tremor with mild asymmetricity between the two hands. So it is probably an essential tremor, which is an inherited instability. So it's a chronic and progressive neurological disease. Its central clinical features is a kinetic tremor of the arms and hand with a slight asymmetricity between the two hands. Even though postural and kinetic component both are found in essential tremor, the amplitude of postural tremor is generally less than that of kinetic tremor. And rest tremor also develops as the disease progresses in advanced cases, and it usually develops in the hands only. It doesn't develop in the leg, unlike rest tremor of Parkinson's disease. So according to 2018 criteria, essential tremor syndrome is classified when there is an isolated tremor of bilateral upper limb action tremor of at least 3 years duration, with or without tremor in other locations, and the absence of other soft signs like dystonia, ataxia and Parkinsonism. So with the features of the above tremor and the duration is, if it is less than 3 years, then it is labeled as indeterminate tremor. And what are the red flags for the essential tremor are presence of an unilateral tremor, tremor predominantly in the legs, tremor in a hemi-distribution, isolated head tremor with posturing, isolated voice tremor, lip tremor and predominant rest tremor. So a next case of a 66 years old woman who presented with tremulousness of head and neck of 9 years duration associated with sensation of aching and pulling sensation of the neck. So on examination, there is tremor of the head with the slight jerky nature, and you can observe the overacting platysma muscle on the right side with slight head posturing, that is laterocolis. It is not simple essential tremor because there is a component of dystonia. It is essential tremor plus. So this essential tremor plus was the new terminology added in 2018 classification. So it is called dystonic head tremor, which unlike essential tremor, it has a jerky nature, and it usually there is a null point phenomenon, that is tremor decreases when the head is placed in the direction of the pull. So it might seem easy to diagnose. However, 30 to 50% of the patients labeled as having essential tremor, during the course of time they may found to have either Parkinson's disease and dystonia. So according to this Bayesian's analysis, any patient diagnosed with essential tremor, we have to observe them periodically for development of other soft neurological signs. During the course of time, they may have a different diagnosis. So another case of posterior circulation stroke, you can observe on finger nose testing, there is an intention component of the tremor, that is tremor increases in severity while approaching a target. It is an intention tremor. So it occurs in lesions of cerebellothalamic pathway. There will be other signs and symptoms of cerebellar dysfunction like ataxia, dysmetria, dysdiadochokinesia and dysarthria. Next, a 65 years old male presented with tremor of the right hand and leg at rest for the past 6 months. There is an associated slowness in his activities and there is mild stiffness. There is no history of usage of any medication or toxin exposure, and there is no family history, and it is the typical rest tremor of Parkinson's disease. So in Parkinson's disease, when the tremor is very subtle, we can ask him to perform activities like mental stress or while walking, and when performing activities with the another body part, tremor usually appears. As in this patient, while walking, tremor becomes more prominent. Next, another type of tremor found in Parkinson's disease is a re-emergent tremor. That is, it appears after an interval of few seconds. That is, after a period of latency, tremor reappears. Here in this patient, you can observe there is a rest tremor. And on asking the patient to keep the arms in front, there is a latency. After a period of few seconds, tremor starts again. That is re-emergent tremor. Unlike essential tremor, essential or postural tremor, in case of postural tremor, tremor immediately reappears on keeping the hands in specific posture. But in re-emergent tremor, there will be a latency of few seconds. So the typical rest tremor of Parkinson's disease has a frequency of 4 to 6 Hz, and it is characteristically described as pill rolling. That is involving the thumb and index finger as if he is trying to roll something between the fingers. Usually the movement in rest tremor is either pronation and supination of the metacarpophalangeal joints, unlike flexion and extension movement in the essential tremor. So there may be other causes of rest tremor, and what are the pearls to identify rest tremor as a Parkinson's disease tremor? In Parkinson's disease tremor, there will be a kinetic as well as postural component may be seen, and there will be re-emergent nature of the tremor will be seen in Parkinson's disease. And rest tremor is usually a late feature in essential tremor, and it usually does not develop in the legs. And jaw tremor of Parkinson's disease and jaw tremor of essential tremor are differentiated by jaw tremor when the jaw is closed is rest tremor, when it is opened it is essential tremor. Next, a 28 years old male with history of consanguineous parentage presented with tremor of limbs of 5 months duration and slowness of activities of 7 months duration. There is a past history of jaundice. On general examination, you can observe the golden brown discoloration of the cornea in the superior quadrant, that is KF ring. So on examination, there is a bilateral tremor when the arms are kept in with elbows flexed and abducted, that is typical wing beating tremor. So it's a case of Wilson's disease. It is one of the most important treatable cause of action tremor before the age of 40 years. All types of tremors are seen in Wilson's disease, and the characteristic pattern is a proximal wing beating tremor. It is unlike a rest tremor of Parkinson's disease, which is predominantly distal. In wing beating tremor, it is predominantly proximal. Next is a 32 years old male who presented with persistent clicking sound in the both ears of 6 months duration with no other neurological symptoms. There is rhythmic movement of the palate, that is palatal tremor or palatal myoclonus. It persists even in sleep. Palatal tremor is of two types, essential and symptomatic. Essential tremor is usually presents with ear clicking sound due to the contraction of the tensor villi palatini. Here the entire soft palate moves. And in symptomatic, it is due to the contraction of levator villi palatini. There is no ear clicking sound. Here the edge of the palate moves and there will be hypertrophy of the inferior olive will be seen in symptomatic palatal myoclonus. It usually occurs due to a lesion in a Gillian-Mollaret triangle, which is formed by red nucleus and inferior olivary nucleus on one side with the contralateral dentate nucleus. Next one is a 59 years old female presented with slowness of activities of 3 months duration and tongue and lip tremor of 10 days duration. There is a history of daily consumption of levosulfide and pantoprazole for 8 months. You can observe the tongue tremor. It is a drug-induced tremor. So it is a drug-induced tardive tremor. It occurs usually secondary to neuroleptic drugs. Next is a 67 years old male who presented with tremors of both upper limbs for the past 2 days. And there is a history of alcoholic liver disease with raised liver enzymes and the serum ammonia levels were raised. You can observe bilateral flapping movements of both hands with sudden loss of tone. This is flapping tremor or asterixis. It is one of the most common reason for referral in ICUs. For flapping hands, we have to look for failing organs. Coming to approach to a tremor, first we have to go with the thorough history like gender, occupation, any task specific nature, community like SE8, Agarwal's community, and age of onset and characteristics of the tremor, whether it is sudden onset, subacute, and part of the body affected, chronology of progression, and aggravating and relieving factors. Like aggravating in case of orthostatic tremor typically appears in standing position, and relieving factors like there is alcoholic responsiveness in essential tremor, and you have to look for other additional features which can give a clue to the diagnosis like dystonia, rigidity, any other cerebellar signs, and other medical history like bronchial asthma, hyperthyroidism, and any history of usage of antipsychotics and prokinetic drugs. And coming to the general physical examination, we have to look for exophthalmos, KF ring, for and in vitals, tachycardia to look for hyperthyroidism, hepatomegaly for Wilson's disease, and detailed neurological examination. For any tremor patient, we have to look for the tremor in all postures like rest, posture, action, and while performing specific tasks. And we have to ask for some writing samples to look for micrographia, macrographia, and while drawing the Archimedes spiral, we can characterize the type of tremor. So after that, management depends upon the underlying cause and the pathology. Drugs commonly used were beta blockers, benzodiazepines, anticholinergics, and management of the underlying disorder. And botulinum toxin will be useful in dystonic tremor, and other surgical management include thalamic lesioning, deep brain lesioning of the ventro-intermediate nucleus of the thalamus, and MR guided focus ultrasound. So the key points were: the first step in the evaluation of a patient presenting with shaking is to determine whether the abnormal movement is really a tremor, because many movements were erroneously described as shaking or tremor, like myoclonus, epilepsia partialis continua, clonus and stereotypy. They are all mistaken for tremor. Myoclonus is usually not regular and it has a jerky nature. And a rhythmic character is the key feature that differentiates tremor from all these mimics, and awareness of the patterns of tremor in various etiological conditions helps in clinching the diagnosis and formulating an appropriate strategy for management. Thank you.
Thanks for an excellent talk, covering the entire spectrum of tremors. Among the tremors, you will realize that the prescription tremor, the iatrogenic tremor which we cause, is really on the top. Especially our psychiatric colleagues, they give fairly a very stiff dose of antipsychotics. The tremors, the tongue tremor, no, it's very peculiar in that it's a triaxial tremor. Each drug, I never understood why. See, for example, in the tongue, when you carefully look, there can be an anteroposterior tremor. There can be an up and down tremor. There can be a horizontal. So it's all the three axes. And the atypical antipsychotics, I think Professor Tarkanand and other senior colleagues, each drug has its own pattern of the moving the tongue in a different way. I never understood. Few have a combined triaxial tremor or combined. Few have only anteroposterior. Few have lateral movements. I mean, I never understood why this. But by and large, I always found the antipsychotic drugs. Second thing is the pride of gastroenterologists or another. Although, in spite of the neurologists shouting at them for so many years, they don't want to leave their pride. They just take pride in writing the pride. But at least I should thank them for providing us more cohort of patients which they create, and then thanks to them for their kindness for using pride. So beware that antipsychotics and prides can. Thank you.
Thank you, Dr. Deepthi, for the excellent talk. So, regarding the latest tremor consensus, is a release in 2018, Professor Bhatia group and all, by the International Tremor Consensus Group. So, the residents can refer to that, but now it is classified into two axes, axis 1 and axis 2, axis 1 being the clinical characteristics and axis 2 being the etiology, pathogenesis. So that would help them in differentiating these tremors. And now after that 2018 again is a repeat consensus given in 2022 asking for amendments regarding the ET and the ET plus. So ET with other signs of dystonia, tremor, or ataxia or Parkinsonism become the ET plus. So it's called as a syndrome. So these are all for conveniences to get the patient to get some drugs or ask them to get these latest technologies that are coming up. It is the transcranial magnetic focused ultrasound. Thank you for that.
Thank you.
Thank you, ma'am. Thank you all. Now we